Hi everyone, welcome to our Myeloma New Zealand session on managing side effects of multiple myeloma treatment. Today's session we are focusing mostly on fatigue and mostly on lenalidomide, but we will talk about other things, and like always, if you've got other topics that you would like us to cover, then please let us know. So we're going to start off with Dr. Henry Chan, who is a haematologist who until recently was our medical director of Myeloma New Zealand and is now joining us from Canada. So we're very lucky to have that. Thank you, Henry, if you want to go ahead.
Sure, thank you, Nicola. Just going to share my screen. So hi everyone. So yes, I am, I was a hematologist at North Shore Hospital. And currently I'm in between jobs before starting my new role with one of the drug companies in Canada. But anyway, I was asked to give this talk about, being tired. And so I thought, initially I thought we can, I'll put some slides looking at all the different literature, what they say, what you can do. But after a while, I found that actually, that may not be useful for our patients because everyone is different. And, we're not here to listen to lectures so that you can go and sit an exam and regurgitate all the data. So I just thought, well, is there any big concept stuff that I can share with people so that when they think about that themselves, think about the tiredness that they're going through, they can try to make sense of it. Because I think once a patient can make sense of their own body, then they can communicate better to the doctor or understand what the doctor is thinking. Then you've got a better relationship with your doctor and you can solve the problem more efficiently. So you can talk about fatigue or other symptoms, doesn't matter. But today we're talking about fatigue. And in my mind, whenever I see patients with fatigue, I think that, well, actually, fatigue is not one thing. Fatigue is a cluster of symptoms. There's many different literature that talks about how you define fatigue. Doesn't matter. It doesn't matter what we call it. If you, the patient, if you feel tired, you're tired. Okay, it doesn't matter how you define it. And being tired can be due to many different things. Okay, and you can easily put that under 4 separate kind of umbrella terms: the disease, so the myeloma, because of the treatment that we give, multiple myeloma or various things, your physical body, and also, of course, the mental or the psychological aspect that's contributing to this fatigue. One thing that I do want to say is that when you look at the literature, you read papers and they say, oh yeah, this study is great, and most people do fine, and most people only had mild fatigue. Please remember that when they call it mild, they often put it under these kind of what we call CTCAE toxicity grading. So 1, 2, 3, 4, 5. Grade 5 means that you die from the toxicity, and then grade 1 and 2 is what we call mild, and 3 and 4 is severe. So usually grade 1 is you've got the symptoms, but it's not affecting you too much. Grade 2 is you've got the symptoms, it's affecting you, but you can still do most things. And then grade 3 is when it's starting to affect your activities of daily living. So you can't cook, you can't do your grocery, you can't, move around the house. But you can imagine, even grade 1 and 2 is still very troublesome because you, as the patient, you are the one living with it. Okay, and so I've heard patients saying to me, "Hey, this treatment, I heard that it's really good, but I feel really tired. Is there something wrong with me?" And I guess the message is, well, there's nothing wrong with you. There's actually something wrong with us, the medical doctors, how we define fatigue and we downplay the fatigue. And so don't blame yourself for being fatigued, okay? And don't blame yourself for experiencing more fatigue than what you think others are experiencing based on the literature. So the 4 aspects. And the first one that I often talk about is disease related. People often say, hey, when I first get diagnosed with multiple myeloma, I was really tired. Well, yeah, but some of the reason is because myeloma, damages the bone, it increases the calcium, and as a result, people can have all of those symptoms, being constipated, being drowsy, off, and also being weak. Multiple myeloma can affect your kidneys, and in some study, not specifically about myeloma patients, but patients who've got chronic kidney disease, you do a survey, you ask them, about 70% of patients do feel tired. Anyway, so pain, of course, pain makes you tired, okay? You can't do the things that you want to do, you walk funny as a result, and there's also psychological and physical stress. Now, coming back to anemia, what I want to say is the beauty of modern day medicine is that we can do blood tests. Okay, we all know our numbers, we all know what our paraprotein numbers are, but you will also know your hemoglobin numbers, right? And you will have patients who go, oh, you know, my hemoglobin came down from, I don't know, 97 to 95, and so now I feel tired. Yes, the number is 97 and the number is 95, but your body can actually cope with a very low number, and everyone is different. So I have patients that, to be very honest, their hemoglobin is sitting at 70s, and actually they don't feel a thing. And at the same time, you have someone who can have a hemoglobin of 100, whom they feel very tired. So my main point about anemia is that, yes, if you look at all literature, you look at all websites, it will say if your hemoglobin is low, you will feel tired. But I can tell you from, well, not for everyone, but in many of the cases, simply having a blood transfusion, you're not going to get your energy back because, as I said from the beginning, people feel tired due to many reasons. And your body, especially if you've been anemic for a long time, your body actually gets used to it. So that even with a low hemoglobin level, your body can still deliver the oxygen to your tissue. And so, yes, if you do need a blood transfusion, the medical team will sort it out for you. But at the same time, I say this to all my patients, yes, you can look at your numbers, but don't get too hung up about these numbers, especially if the drop is, you know, as I say, if marginal. So any decrease of less than 10 in hemoglobin, usually, you know, patients don't feel the symptoms. The physical body is the other element, okay? There's a study that looks at people who were admitted to hospital for medical reasons. So this is not specifically about myeloma patients. In just being in hospital for about 2 weeks, they lost about 5% of their muscle strength. Now, think about it. Next time you want to do some lifting and increase that weight by 5%, it may not sound like a lot, but it is a lot of muscle strength. Like all of a sudden, you know, if you could walk, you know, if you can run a kilometer, you can add another 50 meters on top. And when you're tired, that 50 meters is a long distance. And that's got nothing to do with the disease or anything. It's just simply being in hospital, you lose 5% of your muscle strength. So we talked about, you know, autologous stem cell transplant. Most patients need to be in hospital for what, 2 to 3 weeks? And so even if we're not talking about the chemo, not talking about the neutropenic sepsis and fluid and all of those things, just simply being in hospital, staying in that bed, you lose 5% of your strength. And so you will feel tired. Of course, with fractures, you know, your body is no longer as aligned as it used to be. As I said before, you start to walk funny, you're using muscle that you're not used to. And so all of that add up to that toll on your energy, on your muscle, you know, and so people feel tired. Then, of course, the behavioral thing. So one thing that has been discussed on the Facebook group a lot is sleep pattern. So there's another study showing that people who sleep more than 20% of this, spend 20% of their sleep during the day, rather than just saving it at night. So, you know, having cat naps, they feel more tired. Now, of course, you know, you can say, well, you know, which one's the chicken, which one's the egg? Maybe they feel tired and therefore they need the cat nap. But a lot of it is about being efficient with your sleep. It's about trying to, you know, save up all your sleep so that you get one good long sleep at night so that you can really recharge. Of course, being on dexamethasone doesn't help, okay? It affects your sleep, and which we'll come to here. So as a doctor, whenever you tell me that you're tired, the first thing that most doctors will do is we look at the medication, we look at the treatment. Is there something that we can do? Yes, steroid, I haven't put it in there because it affects your sleep. It makes you tired. Steroids weakens your proximal muscle so that you doing the same thing, walking the same distance is harder work, so you feel more tired. And there has been and me personally, at least in the past, I do want to reduce the dexamethasone as soon as possible and as much as possible. So Joe McCall is, he's the chairman of the International Myeloma IMF, yeah. And he made this very good analogy saying that dexamethasone is like those booster rockets you've got in a space shuttle. So you need that at the beginning, try to get the space shuttle into orbit. But what happened after the initial liftoff? The rocket comes off and you've just got the shuttle going up. So same for dexamethasone, which is, especially for older patients, I try to, yes, we need the steroid initially to reduce the myeloma, but later on try to take it off as soon as possible, reduce the dose as soon as possible. And then stem cell transplant, unfortunately, we always say to our patients is, you go for transplant and then, in 3 months' time, you're going to be pretty much more or less back to normal. And many of you will tell me now that that is a lie. I can tell you that for some patients, unfortunately, 3, 6, 12, 2 years, you still feel not quite the same. And in fact, people have done studies saying that about 1/3 of patients still feel severely fatigued after stem cell transplant for years. And in that study, the median or the average follow-up was 9 years. And unfortunately, that tiredness the proportion of people who felt tired stay more or less around that 33% mark. So it's the treatment, and unfortunately, because there's myeloma, we need to give these medications. But a lot of it, like let's say the transplant, we can't do without, and so we're stuck with it. But there are things that we can do. So for example, as I said, the dexamethasone, we can reduce the dose. And also for lenalidomide, which is, nowadays, a lot of people are on it as maintenance post-transplant, there's room to actually reduce the dose. So many of you are on 3 weeks on, 1 week off. The original 2 study actually started off as just daily continuous, but now people are moving to 3 weeks on, 1 week off because it shows similar efficacy with less toxicity. Now, I'm not giving a lecture about specific drug, but it is just telling people that if you feel tired and if you think it's a medication, talk to your doctor. I always say to my patients, just because I start you on maintenance, it doesn't mean that this is the dose and you have to take it and this is it. You can't change the dose. There's always room to move. There's always room to reduce the dose. 5 milligrams a day instead of 10, or every other day, or having 2 weeks off instead of 1 week off. There's always room. So don't be afraid to try, and don't be afraid to reduce the dose. And on that, I'll just have one last line. No, I'm pretty pushed for time now, which is the slide that I'm sure many of you have seen, is what I use to describe myeloma. So at the start, which is the left-hand side here, I'm hoping that you can see. Can you see my pointer? Where's my pointer? Here we go.
We can see your mouse, like if you want to use that. Oh yeah, we can see the pointer now, yeah.
No. Here we go. So you start off with your disease, which is above this dotted line. So this dotted line is where we say, okay, we can see your myeloma now. So it's like the tip of the iceberg. Okay, and so you've got the disease. We gave you treatment, chemotherapy, whatever regimen, okay? Your disease suppressed. And then it gets down to a point where we can't see the disease. It doesn't mean that you don't have the disease. We can't see the disease. And over time, the disease will slowly come back and then it will resurface again. So the first concept is the deeper the response in general, the longer it takes for the disease to resurface, okay? The second concept is that if we can keep you on treatment for longer, what it is that after just knocking the disease down, it just slows down the growth of the disease, okay? Or maybe suppress the disease even more and it slows down the growth. So with all of that, it takes you longer for the disease to resurface, okay? So I use this analogy all the time when it comes to maintenance. But the main point is people often worry that, well, if I reduce my treatment, so let's say lenalidomide my maintenance, if I go from 10 milligram to 5 milligram, what if I lose control of my disease? Okay, what if, I was going fine and all of a sudden, bang, the disease came back and then I've got nothing. But the reality is that, think about it, even if you were down here and then you just reduce the dose slightly, even if the line comes up a bit faster, it will still be a long time. If your disease was truly suppressed, it will still take a long time for your disease to resurface, okay? But sometimes what people will say is, but I reduced the dose and then 2 months later, the disease has resurfaced. Well, unfortunately, that means that the disease was actually already close to resurfacing. And in most cases, I'm not saying that that's always the case, in most cases, the reduction of dose or reduction of treatment actually didn't do, it didn't make it more resistant. It didn't make the disease more aggressive. It's just coincidental. So why am I saying all of this? Is that I think if you truly have side effects from a treatment and your disease is under control, now remember, there's no way of knowing how deep this is. It could be down here, it could be there. We just don't know because we can't detect it. I think it is fine to talk to a hematologist about trying to reduce the treatment to see if it will make you feel better. Because remember, at the end of the day, we're treating a patient, you as a person, not myeloma and numbers, right? So there's no point for you to live a miserable life because of the toxicity, okay? So that's what I always say to my patient, which is, how about since your disease is under control, let's just reduce the treatment, still keep an eye on it, okay? And see what happens. If the disease starts to surface, maybe we can increase the dose again and see what happens and see if we can get the line down a little bit more, okay? But for most patients, when the disease comes back, it usually, you've got time to see. Now, there will be some of you and some patients out there where things are fine and then all of a sudden the disease rapidly progresses. And that happens. And I would say that that would have happened whether we reduce the dose or not. But I think in general, for most myeloma patients, because we've got the ability to monitor disease with light chain and paraprotein, it is okay, especially if your disease is under control, is to think about reducing the dose of treatment if you truly have toxicity from the treatment. Which goes back to, see, here we go, is that my mouse? Goes back to this point, which is, it doesn't matter whether I put fatigue in the middle or something else. It's important that, for the clinicians, but also clinicians work with patients to think, okay, well, is it truly the treatment that's giving you the symptoms? Is there something else? Okay, is there things like, diet, exercise? Sean will talk about, is there something along the line of, timing of your medication that can actually make you feel better without having to reduce your treatment? And lastly, I have heard this many times where patients say to me, listen, Henry, when I was first diagnosed with multiple myeloma, I was very tired, okay, for all those reasons that we said. And now I am feeling tired again. I'm worried that the myeloma has come back, okay? Most of the time, if the myeloma has come back and is giving you fatigue, okay, usually by then there are other things happening. Because remember, if it was the disease causing the fatigue, it can have all those problems that we talked about: high calcium, the kidneys not being great, your hemoglobin dropping, you've got more pain. So if you're just tired and you don't have any of those things and your numbers are fine, chances are that you're going to be fine, okay? of course, there will always be someone who's an exception, but in general, when the myeloma comes back, it doesn't usually just give you fatigue and nothing else, and otherwise a normal blood test.
Not the expert on the medication or anything like that. I simply work one-on-one with my clients, and we try and create plans to help manage their cancer treatments and their fatigues and whatever symptoms they're really going through better, right? And so it's a bit of a collaborative effort between myself and my patients, but we want to explore some strategies today that hopefully that you can all use to hopefully manage your fatigue a little bit better. Okay, so touching on what Henry said, fatigue is multifactorial, right? Lots of things feed in towards your fatigue. Okay, the medication itself can cause fatigue, sleep problems can cause fatigue, emotional problems, mental health, lack of physical exercise, nutrition, pain, anemia, it all feeds in together, right? And sometimes these causes can also nudge each other on a little bit. And what I mean by that is if you're having poor sleep, we can have mental health issues. If we're having mental health issues, sometimes our pain experience can be a lot worse. And so when you have all these different causes feeding into each other and all of them are causing fatigue or distress or whatever symptom that you're experiencing to be a little bit worse, the overall experience for you can sometimes seem overwhelming, not manageable, and just a bigger issue than it actually is. Okay, and so sometimes it's important to look at the causes of your fatigue or look at the cause of your fatigue, try and break things apart because it helps us manage these a bit better. Okay, so let's move on to some strategies that I put forth that I normally work through with my clients to help manage fatigue. Okay, can everyone see this all right?
Yep, we can see it great.
Okay, so first strategy that we've got for fatigue is recognizing that you are fatigued. Okay, so quite often with cancer and its treatments, you wake up, and I like to give the analogy that you've got 50% of your normal battery. Okay, you haven't been able to fully charge yourself. Okay, and we know that during the day, each thing that we're going to do is going to take a little bit of our battery and slowly wind us down. Okay, so it's important to recognize this and appropriately plan our day, because we're not going to have all the energy to fit in everything. Sometimes we're going to have to miss out on some tasks. Sometimes tasks are going to be quite hard because we don't have much battery. Okay, so recognition that you have this energy is important. Let's see that question for Dr. Chan. Okay. Things aren't moving on. Okay. So strategy 2, we've got prioritizing. Going back to what we said before about having less battery, having less energy to do what we want to do, we need to prioritize the activities in our lives that are meaningful to us. So what's important, what's not important, what can be delegated to others, and what are things that we can completely disregard. So it's important to realize that you're not going to be able to get everything done, or not going to be able to get everything done without feeling fatigued. So if you could choose specific activities that need to be done, that are really, really important, prioritize those and get those tasks done, delegate what you can't do or what is not manageable to someone else, okay, like a partner or family members, and other tasks that just aren't important, like mowing the lawns, like you could just leave, you can throw them out the window. Okay, so prioritizing those tasks is really important as well. Okay, third strategy, we've got pacing. Okay, so going to those important tasks that we've prioritized. Okay, we want to space them out throughout our day. Okay, we don't want to do things back to back to back. So if what you considered was important was waking up, walking your dog in the morning, making meals, I don't know, dropping kids off to school, you want to space these out throughout the day. Getting them all done within 2-3 hours in the morning is boom bust behavior, and will likely make you feel quite crummy later on. Okay, so instead, space them out, take regular short breaks in between doing these activities. They'll help them feel much more manageable. All right. Fourth strategy, exercise. So this is a little bit more about what I do on a regular basis with my clients. So fatigue is very person to person dependent, and the type of exercise that we do with them is person to person dependent. Okay. So some general advice that I give to people that are just starting out is that we want to do short sessions. Okay. These sessions are regular, so we do them daily, but we don't want to exceed your capacity or drain your battery so that you're feeling too tired, unable to do anything else after our sessions or the day after. So those exercise or activity sessions can be as short as a 5-minute walk around the block, a very short period of resistance training, whatever you enjoy. I do not discriminate. You pick something, and as long as it's within your capacity, we can do. Okay. Next factor about exercise is it needs to be invigorating and not depleting. Okay, so you need to finish the exercise feeling fantastic. We know that endorphins are produced when we exercise. We know that all these good things happen and we can feel great. Okay, but we want to stop at that point. You don't want to continue on until you're too exhausted and you're done. Okay. Going back, type, intensity, frequency, and duration is all individualized. The best advice that I have there is keeping it short. It's symptom based. Okay. Finally, with the exercise and your fatigue and what you can manage, we want to use something that we can monitor how you're going, monitor where you are at the start, monitor how you are a few weeks down the track. Okay, so clinically, I use tests. So we use tests such as the 6-minute walk test, which is a general aerobic capacity or activity tolerance test, and I use also a couple strength tests. But you don't have to use tests like that. It can be something a bit more simple. It could be last week or when I first started, I could walk the dog for 5 minutes and I felt fine, but now I can walk the dog for 20 minutes and I feel fine. As long as you've got a marker, something to monitor yourself, we can track how you're going, or you can track how you're going. And that can often make you feel a little bit better about the little changes that you have, because managing fatigue is something that takes a wee while. Okay. So I can come back to exercise a bit later if anyone has more specific questions. I saw there was a lot of questions on hydrotherapy, maintaining muscle mass, and other things as well, which are all important but are not applicable to everyone. So I'm happy to answer those questions at the end. Moving on, talking about replenishing our battery. So we actually have something to do. We want to find something that relaxes us, that gives us time to unwind. Okay, everyone's a little bit different. Okay, we all find that we enjoy different things. So I quite like spending time in nature, and I enjoy sensory appreciation, which is like getting in touch with what you smell, what you feel, what you hear, what you can see, and that helps me unwind at the end of the day. And that might not work for others. Others might enjoy meditation, might enjoy yoga. That might make them feel better. But whatever gives you a boost in your battery that you can do throughout the day, something that you can schedule down, would be pretty good for you as well. The last strategy that I have is to set a target. Okay, we want to be able to work towards something that typically makes it a bit more meaningful to you. Okay, it doesn't always have to be. You don't have to set a target like I want to run a marathon. I want to be able to do this, do that. It can be much more simple. It could be as simple as you want to rest for 20 minutes per day, or set some time aside for you, or you want to communicate more with your partner, or go outside 5 times during the week. It can be quite small, but it's something to work towards helps with motivation. It gives you something extra to do. Okay. It helps us also set in place better plans and gives you an objective and little markers, things that we can monitor along the way. So setting targets is quite important as well. So that's the end of the strategies that I have. Okay. And I'm happy to answer any questions about exercise or anything else that are there.
Fantastic. Thank you so much, Sean. So we've got some questions, which some of them are ones which I'm not sure if it's a you question or if it's a Dr. Chan question. So there is a question about using a swimming pool, which I guess with neutrophils and stuff. I'm not sure if you can answer that or if you want to leave that to Dr. Chan.
I can probably chip in a little bit there. I used to be a lifeguard, and we generally give some advice about going into public spaces. So whilst you are potentially immunocompromised, so any sort of medication that may do that, and Henry could touch on that in a bit, we typically tend to advise to avoid public spaces. However, communal swimming pools, public swimming pools, the chemicals that are put into them generally mean that the water is actually quite safe. Okay, so I generally avoiding public areas. But if something was important to you, it was something that you wanted to engage in, you could always go at a time that is fairly not that busy. You could always go on around midday where you don't get the before school and the after school rushes. And I think you'd be relatively safe in the water itself. Yeah, would you agree, Henry?
Yeah, I agree. I think the problem is if you look at the guidelines that say, okay, if you're immunocompromised, you need to avoid these places. They don't really define what immunocompromised is. Same, nowadays we're going through COVID, which is, well, how immunocompromised am I? And every myeloma patient is different. Those who are just been diagnosed starting chemo, those who are on maintenance, those who are advanced relapse refractory. But I do agree that the actual water in the swimming pool with all the chemical is actually pretty clean. So I think the swimming is in itself, if you're well enough to actually get to a swimming pool for myeloma patients, you'll be fine. Okay. These I would agree with being just avoiding crowded places, just because of that infection risk, changing room and all of that. But if it's not a busy hour, then I think that's fine. I think a lot of the literature when it comes to, swimming pool, it is just based on expert opinions, and they're mostly for patients who are chronically immunocompromised. So people, who've got ACE and HIV, ACE, or people who are, organ transplant on lifelong immunosuppressants. Whereas for myeloma patients, most of us, although we are immunocompromised, it's not actually too bad. And so I don't think we need to be as worried as those other patients. So I think the actual swim, as I say, is fine. Totally agree that we should avoid, or minimize contact in crowded places where people can cough and sneeze. Yeah.
That's great, thank you. And just a reminder, everyone, we're recording as well. So just when you're asking your questions, this is going to go up onto our YouTube channel. So just keep that in mind with your questions. Megan, you've got a question.
I'm glad you said that, Nick, that it's going to be recorded. I will be very, very good. Sean, just a question. I suppose as a physiotherapist, all of us see you as sports injury. You go for after an injury or something, and obviously with myeloma, with bone damage or bone pain. And I know you do posture, you do exercise, you do muscle strengthening and that, but I don't know if you can answer this. Things like massage, I know you're a physiotherapist, but I've heard people actually say they go to a physiotherapist for massage because it's cheaper than going to a masseuse because they haven't got a specific injury. Osteopaths and that do what they call maintenance therapy. So you can go, even though I haven't got bone pain or bone damage, sometimes you need a rejig of your body. I don't know if a physiotherapist actually does that. I know the other practices do. But it's just a public perception of what a physiotherapist, you always see the ABs or somebody going to a physiotherapist, or when you've had an injury at work or your back. So can you actually go to a physiotherapist that is, when I say oncology approved, because there's certain people that we should go and see that are registered or recommended by the Cancer Society or something, but can we do good things for our body besides just manipulating or doing something? Can we go to a physiotherapist for this, Sean?
Yeah, so I'll just speak a little bit. So physios and what I do at Harbour Cancer. So I'm an oncology physiotherapist now. I used to work for a professional sports team. So I've moved on. But usually what I talk to my patients about, so people are undergoing chemotherapy or other medications for cancer, is that exercise and muscle mass is generally protective of the worst of the side effects that you have whilst on treatment, okay? And not just the side effects of the treatment, but the side effects of cancer itself. And we do have specific guidelines around what exercise is better, and most of the exercise does focus on progressive resistance training because skeletal muscle mass is the most protective feature against those side effects. But at the end of the day, if resistance training isn't for you and you aren't interested in that, you're not going to engage in it. And I'd rather work with you to find something that works for you. So that's what I do here at Harbour Cancer, and that's what oncology physiotherapists do. There's also lymphedema specialists. We do acupuncture as well. I don't do that side. Other physiotherapists do that. But that helps manage pain. It helps manage, all those like niggles that you can feel, like you said, like people sometimes require an adjustment to feel a little bit better. Okay.
Yeah, I think the thing is about that muscle retention, or how can I say this? I'm a middle-aged woman, and I actually like I'm looking for endurance and strength. I'm not looking for weight loss, an hourglass figure. I want good muscle, because I'm with the chemo, I've been on drug trials, stem cell transplant. And as you get older, naturally, that the muscle tissue, and to me, it's really important. I was sort of, when I say joking about the massage, I mean, at the end of the day, I think that for me is, I do want that strength and that development of muscle. And, I mean, people say, oh, bodybuilding, but that's crazy stuff. That's another realm, and that's a life, that's a dedicated thing. But I just want to retain my an endurance and a good strength, and have not the bat wings, and I actually do believe in weight resistance, and especially women. I don't know why women are a bit frightened about that, but I think endurance is right. So sounds like you're the man for the job, Sean.
Yeah. Well, so in terms of when people come to me and they ask for, well, what's the gold standard and what can they do? It's completely in line with the American College of Sports Medicine exercise guidelines for the healthy population. Okay, so there's no difference between cancer patients and the healthy population, which is 2 to 3 resistance training sessions per week. We typically quantify it through a moderate intensity, so your heart rate's not going through the absolute roof, but light exercise, you need to, actually have some exertion whilst you're moving, okay? And for no more than 30 minutes, okay? So you can stay quite short. Aerobic wise, also same, 2 or 3 sessions per week, moderate intensity, no more than 30 minutes, okay? So when people ask for the gold standard, that's typically where I go, okay? But again, changes for other people. I also wrote, as a part of my undergraduate studies, I did a systematic review without meta-analysis on exercise in hematological cancer patients, either before or after post-stem cell transplant. I'm happy to forward that paper on to people if they want to read it, but very, very, very similar, like whole body exercise, resistance training 2 to 3 times per week, at about 30 minutes, moderate intensity, same with the aerobic. So same as before, 2 to 3 times a week, 30 minutes, moderate intensity. That's all that's needed. So yeah, I hope that answers. Oh, and to go back to your question about are there physios out there and who can you get in contact with? There's a fantastic organization called Pink and Steel. Some of you might have heard about it. It's a physio-led organization.
Yeah.
Yep. I'll explain anyway. Physio-legal organization for people with cancer or after cancer, basically designed to get people moving again or start managing life a little bit better after cancer treatments. And I think that we often make a huge difference in people's lives. So I definitely recommend checking out that website if you haven't already. Okay.
Thank you. And we've got another question, Sean, just really quickly before we leave. Someone's asked, with the muscle mass loss from stem cell transplant, what type of exercises would you recommend doing to improve strengthening, especially loss in the legs, but I need to be careful about lower back pain? Do you have any recommendation?
Okay, so they've lost muscle mass, they have lower back pain, and they want to do some exercises. So lower back pain is complex in itself. Okay, there's multiple causes of lower back pain, and I'd like to bust any myths of like needing specific exercises to improve lower back pain. We just know that exercise in general helps, and the best way to think about it is keep it simple. If it feels good, it's likely good for you. If it doesn't feel good, it's probably not good for you. So if you can't do a squat, but you can sit up and down from a chair and that feels fine, that would be a good resistance exercise to start with. If that feels fine with load, so holding on to a weight, for example, and then doing the exercise, that could feel fine. Other people prefer to lie down on their back because they don't like compressive forces, and shear forces feel fine to them. So they could do things like a bridge or a hip thrust. And again, the same, it feels good, it's good. If it doesn't feel good, it's probably not so good. Same with load. Slowly introduce load as you feel like you can and it's not painful. And on a weekly basis, look at improving or increasing that load so that the volume of what you're doing is going up. And over time, tissue resilience usually follows, and strength and muscle mass will come as well. I hope that answers that question.
It does. Just getting through the questions. So someone doesn't suffer from fatigue much, but gets muscle cramping throughout the day and night, and it's a problem. Is there something you can help with that, or is that a question?
There's, in terms of exercise and what we can do to help cramping, typically look at cramping as an activity dependent thing. So sometimes people can under exercise or not do enough activity, not have enough strength, and that can cause cramping throughout the day and night. Other times it can be the over exercises that get cramp. So sitting somewhere in that middle point is probably about good for you. So normally with cancer patients, we typically fall on the under exercising side. So doing exercises that target that muscle in particular to stop the cramping. So for example, if it was your calf, you could do a calf raise. If it was your hamstring, you could do bridges. Find an exercise for that muscle or muscle groups, and slowly begin to strengthen it up. On the reverse, if it was a muscle that you use all the time, so it was your calf and you do lots of walking, because you are slightly more active, you might need to wean back on the walking a little bit, start improving the strength first, and gradually reintroduce that walking or build it back up. From my perspective, that's where physios usually approach the cramping issue. Yeah.
Awesome. Thank you so much. So I don't think we've got time for any more questions for Sean, but thank you so much. It was just an absolutely fantastic session. And thank you so much. And we've also got a little thank you that we'll send through to you next week as well, just to say thank you so much for enlightening us on our bodies, really.
Well, thank you.
Cool. Thank you so much. Right. So then over to Dr. Chan then. So we've got a few questions. I'm not sure, do you want to sort of just go through them, or would you like me to read them out for you? Or
No, I can go through them. So in the chat, there was a questions about lenalidomide maintenance and how many patients don't actually take lenalidomide maintenance. I guess the short answer is I don't know. It really depends on the clinicians and how the patients were told. Personally, I can't think of any recent patients of mine who didn't have lenalidomide maintenance. I know that some clinicians are slightly concerned about lenalidomide maintenance because of two reasons. One, with lenalidomide maintenance, it does increase your risk of secondary cancer. The risk based on that study is about 8% compared to those who didn't take lenalidomide maintenance, which was about 2 to 3%. And then the second thing, which is more of a New Zealand thing, is that we all know we don't have access to many drugs. And once you progress on lenalidomide maintenance, there's nothing else. So in New Zealand, we've only got bortezomib and lenalidomide. And so some people want to save the lenalidomide for later. There is no data to say whether you should save it or not. But if you extrapolate the data, what you will see is that, yes, you can save it for later, but the period of remission that you have after transplant is shorter. So you relapse sooner and then you give the drug again later. So it works out to be about the same. At least the international, what other international expert will say is, yes, although it may work out to be the same on paper, each time when you progress, the chance of you being able to get the next line of treatment reduces over time. Okay, so it doesn't mean that you progress and you will definitely be able to get the next line of treatment for many reasons. One, there may not be a next line of treatment. Two, at the time of progress, it may progress so quickly that you don't have time to actually get to the next line of treatment. And obviously, each time the disease progresses, you can potentially have damage to your kidneys and more fractures, and so that can affect you. So that's why, as I've said in the last many years, I'm a believer of lenalidomide maintenance, and so that's how I counsel my patients. So there's that question. There were some questions, I think, about lenalidomide maintenance. Is there any point to do that beyond 2 years? Currently, we say that you stay on lenalidomide maintenance as long as it's working. There have been studies showing or comparing finite duration of lenalidomide maintenance versus ongoing, and ongoing in general still give you better outcome than finite period. And that's also why I tend to tell my patients, if they have toxicity from it, if they feel tired, I would much rather that I give you a lower dose and you stay on treatment than just keep trying to push that standard 10 or 15 milligram dose to a point where you just get so fed up with it, you're so tired from it, and you have to come off it. So much rather that I reduce the dose and keep the patient on lenalidomide maintenance because of that data showing that it gives better outcome. There was a questions about peripheral neuropathy. Peripheral neuropathy and management is difficult. Bortezomib, thalidomide, lenalidomide, the common drugs that we have in treating myeloma, all of them can give you peripheral neuropathy. They have slightly different pattern. And neuropathy is one of the reasons why bortezomib was initially only given for 9 cycles and not indefinite. You can go beyond 9 cycles. Everyone is different. We say to our patients, you stop it, it will slowly get better, but it is a slow process. Some people, their nerves are never quite back to their normal self. In terms of management, it's mainly pharmacological, so drugs. So things like gabapentin or pregabalin, they're usually very good. In the past, we use things like nortriptyline or amitriptyline. The current data shows that they may not be that great. I sometimes use them, especially if people have nerve pain at night, because amitriptyline does make you slightly more sleepy and help you sleep a little bit. But in terms of actual nerve pain, gabapentin and pregabalin are usually better. So there's the questions about the neuropathy. And then chemo brain, how to deal with it. There is no, silver bullet for chemo brain. I do think that the chemo brain is related to what we've discussed today about fatigue, because obviously if you're tired, if you have a bad sleep, you're not going to be able to think clearly, and so it is just doing all those things that Gemma and Sean has suggested, exercising, having a good balanced diet, and then from a medical point of view, trying to minimize your treatment as much as possible. So if you don't need such a high dose of dexamethasone, maybe reducing that. No doubt, lenalidomide makes people tired, and if that is contributing to the problem, cutting it down. So unfortunately, there's no perfect answer. It is that diagram that I've shown, fatigue in the middle, the 4 aspects, and trying to address all 4 of them and try to make things better. And with that, I think I've covered most of the questions.
Yeah, so I've just got another one as well, and this might be too technical for you to answer off the top of your head, I'm not sure. But what would you, so, when we're on lenalidomide maintenance, we usually have a blood thinner, and I think most people probably have aspirin, but we do have people who have rivaroxaban as well. If someone was on rivaroxaban on len because they'd had a previous clot but was wanting to have curcumin, do you think the blood thinning effect of curcumin with aspirin, how's that compared to just rivaroxaban?
Yeah, so just backtrack a little bit. So normally, if you're just on lenalidomide maintenance and you didn't have any history of blood clot, I wouldn't put patients on blood thinners. And if you look at the IMWG recommendation, so the International Myeloma Working Group recommendations, I don't think they suggested using blood thinners. So blood thinners is important if you're on thalidomide. Blood thinners is important if you are being treated for myeloma using lenalidomide and dexamethasone. So dexamethasone increase your risk of blood clots. So yes, in that part, we would suggest you go on a blood thinner, but just post-transplant maintenance. So by then your disease is nicely suppressed, your lenalidomide dose is low dose, and you're just on lenalidomide, not on dexamethasone. Usually I don't give people blood thinners. I think if you're on blood thinners for whatever reason, and then obviously we had a discussion earlier on about, curcumin and blood clot, curcumin and rivaroxaban. My suggestion, and I know that it kind of go against what we have just discussed earlier on, my suggestion will be stay on your blood thinners and don't take the curcumin. And the reason for it is because although, yes, there is data to support curcumin, as far as I know, there hasn't been a phase 3 study comparing, say, curcumin and lenalidomide together versus lenalidomide on its own. So yes, there could still be a benefit with the addition of curcumin, but the short answer is I don't know how big that difference is, that improvement is. Whereas if you have a risk of blood clot, and for patients with myeloma, the risk of blood clots is very high. And so if you already had a blood clot or you're on treatment because of, you're on treatment that increases your risk of blood clots, then your risk of blood clots is much higher, and therefore not taking blood thinners give you that substantially increase your risk of blood clots. And blood clots, yes, it could be just as a minor as a clot in the leg, okay, but blood clots can also go to the lungs, and that can severely affect you. And so in that setting, I would say stay on the blood thinners and not take the curcumin.
Thank you. And I think actually for me, that sort of highlights one of those things that as a patient, we'll often hear people talk about things, and it's sort of that FOMO, the fear of missing out of, could I be doing something that could be working for me? But I think you're right that it's only more recently we've had more people on lenalidomide maintenance. And what we're talking about sometimes is people who might be using curcumin for the last few years and doing great, but who weren't even on lenalidomide maintenance. So if you are on lenalidomide, you're still already getting something really good. And I think that's the thing that can be hard sometimes with myeloma is you almost can't compare yourself to other patients. You really do have to just look at your situation. So that's great. Thank you. Megan's got a question.
Oh, thank you. Sorry you've left our shores, Henry. Great loss. But congratulations, Toronto. I just want to talk about the dreaded DEX. I suppose you're saying about Len that you can modulate, you can decrease it, and you can you don't need to be frightened by quality of life as opposed to because you drop it down to 5 milligrams or whatever it is that the cancer's going to come back. Are you of the opinion, you went to the good conference in Queenstown where Dr. Joe, he said, get off DEX as soon as you can. I won't say who my haematologist is, and he's a bit of a statistician like you, Henry. He believes that you need to get off it as quickly as you can. I don't know if he's a Dr. Joe, get it off that quickly, but should people be reducing DEX, stopping DEX? I know there's the 2 years with Len and all this secondary cancer, but with regard to DEX, is it advantageous to try and you've had your stem cell and there's a sort of a time that you should do it, but is there a time when you think, no, you need to stop DEX now? It's not getting the benefit. You've had the hit, you've done that, and now it's time to stop. Thank you.
So how long is that time? I think you're asking.
Yes.
Yeah, great
yes.
question.
Yeah.
Great question. Once again, just like many things in medicine, if we go by the literature, that what clinical study, that there is very little data on. The only recent modern study that looks at reducing the dose of DEX or dropping DEX was done in an elderly myeloma patients, a group where they give lenalidomide and dexamethasone for a period of time, and then they drop the dexamethasone later on, and they compare that to those who stay on lenalidomide and dex long term, and the outcome was exactly the same. And so I think, and there's also the reason why if you look at lenalidomide maintenance post-transplant, we just do lenalidomide. We don't give dexamethasone or prednisone. And so I think personally, I do think it is reasonable that once your disease is under control, okay, so you've achieved your response, you've got a very good partial response, or your numbers are nicely suppressed, then it is okay to start thinking about reducing the dexamethasone. I certainly do that for a lot of my older patients who are on lenalidomide. I think some patients you need to be a bit cautious, especially patient who had a rapid disease progression, and then you finally manage to get their disease under control after combining different drugs together to get it under control. Then I am a bit cautious, especially in New Zealand, because I'm worried that if they lose control, I've got nothing else left. Okay, but ignoring those situations, I do think that it is the field should eventually move to a point where we keep cutting down the dexamethasone dose. I can't tell you, whether it's after 1 cycle or 2 cycles. I think everyone's different, but I do think that, especially if you're not talking about frontline transplant patients, you're talking about relapse setting, if your disease is under control, then there should be room to reduce the dose, especially if you have toxicity. But unfortunately, I can't tell you the exact magic formula because no one knows.
And okay, sorry, and I don't want to make it sort of personal about my case, but I had a SCT. We had the 40, the usual 40 weeks on or whatever. I'm now down to 12 milligrams a week. So, and I sort of get the impression from my hematologist, he's always quite keen to taper it off totally. I only got a VG, only, she says, but I got a VGPR. So, and everything's moved into the normal range. I suppose, I know, Henry, it's like how long's a piece of string? That's why it's incurable, because it's such a crazy disease that has variables. But okay, so I'm only taking a small dosage. Maybe I can push it longer. It's advantageous to push it longer.
Push it longer as in keep taking it for longer.
Yeah.
As I said, there's no data, and the reason why DEX has been around for all regimens because DEX was the first medication that was proven to be effective in myeloma, and so everything just add on top of it. And when drug companies want to do clinical trials, they don't want to take things out because otherwise people go, well, you're not comparing apples with apple. So everyone just sticks with dexamethasone in as a backbone.
Yeah.
I think for everyone else, I guess the comment is if your hematologist says to you, listen, hey, your numbers are looking great, you're doing fine, you're taking the dex for so long, maybe it is time to cut back. I guess my comment is in that case, that is okay. So don't, because as much as, some patients doesn't want to take medication, some patients also get very anxious about taking less than what they used to have. And I think my comment is, if one day someone says to you, hey, listen, I think you're doing great, let's cut back a little bit, then the take-home message is it's okay. Yeah.
So you're not Dr. Joe cold turkey. If you're doing great, I've got good health, the numbers are good, everything's under control, I've had a good MRI, you don't believe in a cold turkey, just stop. Well, we live in New Zealand, so we're third world, of course. Oh God, I shouldn't have said that. Sorry.
I tend to just slowly taper rather than cold turkey. Partly, it's actually not because of myeloma. As I say, I don't think stopping you from 20 milligram weekly to nothing is. I don't think it's going to make any difference. But that does affect how you feel in terms of your energy level, your sleep, your mood. And so just going cold turkey on that, after you've taken it for, I don't know, 2 years, it can be quite a big shift. So for that reason, I taper, not because of the myeloma.
Say you're on 5 now, that's nothing. 5 to 0.
Oh, yeah. So they come in 4 milligrams. So if you're already on
that's
4
right.
or 8 milligrams,
12,
then I'll just stop. But if you're on 20, then I usually cut down and then stop. Yeah.
Oh, good to hear. Thank you, Henry.
Thank you so much for that question. Does anyone else have any other questions? I think that might be us then for the session. Thank you so much, Dr. Chan. This has been just really helpful session, I'm sure, for absolutely everybody. And like we said at the beginning, there will no doubt be other things that you want to know that we wouldn't have had time to cover off today. So you're welcome to email us or message us either in the Facebook group. So if you found out about this either through our social media or through our emails and aren't signed up to our Facebook group, you're welcome to join our Facebook group. It's Myeloma New Zealand. So the Facebook group of Myeloma New Zealand, and you can also sign up to our emails as well. And let us know if you've got other topics that you would like us to cover off in the future. But I'd just like to say thank you so much to Dr. Chan for the session, and to everyone else joining us on a Friday afternoon as well. I think we've all done very well for a Friday afternoon.